Hi, Coceka. I think we are probably ready to go, if you like.
All right. Thank you very much, Carrie. And good afternoon, colleagues. And we are excited to host you today in South Africa. Would like to welcome our colleagues from South Africa, from Zimbabwe, from Kenya, and from Uganda. We appreciate you joining us today, and in South Africa, we are very much excited to host today's session, and we are looking forward to be sharing with you some of the lessons that we've learned in implementing our condom programming. You'll see in front of you there's that is just giving us some information to say, you can say hi in the chat box, let us know who you are and where you're from, so that we can see who attended today's session. In the participants tab, you can raise your hand if you'd like to speak during the discussion or you'd like to ask a question. You can also use the chat box to ask questions and to leave comments for us, and we'll be able to look at those while we are continuing with today's program. So today we are here invited by our beloved South to South Learning Network, and thank you very much South to South Learning for bringing us as 10 countries in the continent to provide us an opportunity to gain experiential knowledge from our peers, as well as harness and share some good HIV prevention practices and empower our countries to be able to adapt the HIV interventions and align them with our uniqueness in the African continent. And we also would like to thank some of our key partners and key stakeholders that have made South to South Learning Network concept a reality for us in Africa. And would like to give some accolades to our partner, Genesis Analytics, who is housing and hosting the South to South Learning Network. Thank you very much for the hard work that we've been doing to bring us together, supported by the University of Manitoba and funded by the Bill and Melinda Gates Foundation to be able to drive this agenda. Would also want to thank UNAIDS under the Global HIV Prevention Network for assisting us to conceptualize this platform and be able to share with our neighboring countries some of the work that we are doing. Countries that are currently participating is Kenya, Ghana, Zambia, South Africa, Malawi, Tanzania, Uganda, Nigeria, Mozambique, and Zimbabwe. So we would like to make sure that the South to South Learning Network focuses on 2 HIV prevention pillars, that is condom and key populations. And with key populations, we are limiting our coverage to female sex workers and men who have sex with men. We've identified those to be our key focus priorities for this cycle of the South to South Learning. So colleagues, we welcome you to the South to South Prevention, HIV Prevention Learning Network that South Africa is hosting, excuse me, with an agenda focusing on multi-year procurement, budget planning, and allocation of domestic resources for a successful national condom program. So in South Africa, we are hosting this session because we would like to think that a South to South Learning Network told us that we won the race when we were filling in the self-assessment tool to assess where the countries are with condom programming. So we were then requested to say, let's come together, support other countries by telling them and sharing with them some of the successes and some of the planning that we have undertaken as the country to be able to be where we are with our condom program. Just quickly, colleagues, before we go far, just a quick background on South Africa. I think we are hosting this session today as a country that is really in mayhem. You have seen in the news that we've got some parts of the countries that are having riots, and we are hoping that our government is going to be able to address those and we go back to stability, because our main concern as a country is the fact that we are right in the middle of a third wave of COVID-19. Our COVID-19 statistics to date, we've got more than 200,000 active cases in the country. So for us, it's a very great concern of where we are, especially in terms of our HIV programming as a country. As we all know, in the country, we've got about 7.9 million people currently living with HIV. Our number of people currently on treatment has been fluctuating around 5 million. With COVID impacting in that number, we had quite a high decrease or high loss to follow up of our people currently on treatment. And now we are trying to come back on track to be able to meet our target of putting 90% of the 7.9 million people living with HIV on treatment. Our biggest fear and our biggest challenge as a country is the new infections. We've got about 232,000 new infections annually as recorded in 2019 when we were looking at our Ntabiseng model, which is a model that we use for estimations. So for us as a country, our condom program is a cornerstone for HIV prevention, and we would like to share with you our current strategies. So in terms of our agenda, we'll be understanding the context of the South African condom programming. We will be looking at the procurement and supply chain. We will be looking at the domestical finance and sustainability of the condom programming, and then we'll have open discussions. So we'll first take the presentations, and then we'll come back for discussions and questions as we go ahead. So welcome, and we are happy to be hosting you, and we are happy to be also getting some of the comments and lessons learned, and also some of the successes from the different countries that can also continue to strengthen our condom program. So today, in terms of the people that have been the backbone of this presentation, supporting our South to South Learning Network colleagues, is myself as a facilitator. I am Coceka Nogoduka. I'm the Executive Manager for the National Strategic Plan Implementation at the South African National AIDS Commission. Supported by Celeste Madondo, is the Technical Lead for HIV Prevention at the South African National AIDS Council. Supported also by Dr. Ntsikimanzine Matebula, who's a Program Specialist for Sexual Reproductive Health and HIV linkages at the UNFPA. And our speakers today, we are working with our colleagues from the National Department of Health that will giving us the different presentations. That is Dr. Thato Chidarikire, who is the Director for HIV Prevention Strategies, Mr. Ntabiseng Khoza, who is the Director for HIV and Conditional Grants in the Department of Health, and also Livhuwani, our Deputy Director for HIV Prevention Strategies and the Condom Program at the National Department of Health. So these are the colleagues that are to share with us some of the work that they have done to ensure that as a country, we have a sustainable condom programming. So we're going to kickstart with our agenda and our program. Colleagues from the South to South Learning Network, if you can share with us the screen so that we can look at the different questions that we want our participants to look at. Are we ready for that, Kerry?
Yes, we are. We'll share them in a second. You should see them now.
Yes. Colleagues, in front of you in your screens, we've got the open poll. We are asking 3 questions from you. Oh, we are asking a couple of questions. The first one is, how many condoms does South Africa normally distribute per annum? Second one, what proportion of a condom program is funded by domestic resources? Condom use in South Africa is, so you'll choose a question. And the question 4, there are approximately X number of condom brands in South Africa. So you will choose a number. And then the last question, who is the largest procurer of condoms in the world? So we would like you to share your questions, your responses. You click on the correct answer. We will be putting together the poll and we will tell you what the results are. And we might even have a winner. So please take part. We'll give you 2 minutes just to look at the questions and click the correct answer that you think is click an answer that you think is the correct answer. All right, I think, Kerry, we can continue. So those are the responses that we've got. Thank you, colleagues, for participating, and thank you for your inputs. Kerry, we will answer these questions at the end of the presentations, but also if you listen carefully to the presentations today, these questions will be answered by our presentations, but we'll also at the end of the meeting take a quick snapshot and tell you which are the correct answers for the poll that we had today. We will now continue with our program for the day, and we will take our first speaker that is going to give us a presentation, which is Dr. Thato Chidarikire, who is the director of the HIV programs in the National Department of Health. Her portfolio that she is responsible for under HIV prevention includes HIV testing, pre-exposure prophylaxis, post-exposure prophylaxis, condom programming, STI management, communication, and stakeholder management for HIV prevention for the Department of Health. She has over 20 years professional experience gained in academia, public health sector, and research units, and with 17 years in the HIV field. Her vast experience includes policy and guidelines development, HIV prevention interventions development and implementation, research and clinical trials coordination and management. Thato co-chairs the WHO HIV testing guidelines development group, the national, the South Africa PFIP prevention workstream. This is a PEPFAR implementation structure that coordinates the implementation of PEPFAR programs in South Africa. She is a member of the National HIV think tank. Thato holds a PhD. She's a PhD graduate from the University of Witwatersrand with a specialty in virology. I'll hand over to you, Dr. Thato Chidarikire.
Thank you very much, Ms. C, and good afternoon, everyone. Next slide, please. So as already presented or introduced, I will be talking to the condom program, mainly the overview in South Africa. And I have my colleagues who will talk to different parts of programming of the condoms in the country. So we start at a bit of a background in terms of epidemiology, and here we see our 1990, this is up to March 2021. And as we see with all the graphs, we can see that the first 90 has relatively been reached, in terms of the country in general, in terms of male, in terms of females as well. Our challenge is with young people under 15 years. So we're starting there because now we are moving on to the 95, 95, 95. And as you can see, we are still a few steps trying to move towards there. But our progress does not just start on the or end on the first 90. We still need to work towards the second 90 and the third 90. And that is why prevention is very important to ensure that those who are HIV negative actually remain negative, while those who are HIV positive are actually transitioned through the cascade. Next slide, please. So as I mentioned before, our challenge is mainly in the young people, but also when you look at gender, our challenge is more in the males as compared to females for different reasons. So the country's response to HIV and STIs and TB is through our national strategic plan. At the moment, we're still using the NSP 2017 to 2022. And when we look at our goals, the first goal really is accelerating prevention. And we actually, even from the previous NSP, we're implementing prevention in combination. And this is based on the fact that there is actually no one size fits all. So there is no one intervention that can actually deal with all the challenges that we're having in terms of prevention. So we combine biomedical, structural, and behavioral interventions. And as you see on this slide here, we also have a minimum package of each intervention. On the biomedical side, we are looking at male and female condoms and lubricants, HTS, and we know that HTS is actually entry point to HIV and AIDS programs in terms of one needs to know their status in order to be managed further, whether it's to be referred to prevention interventions or to be referred to treatment. Condoms, our chair has already said or mentioned that they are a cornerstone for prevention, not only of HIV, but other STIs, as well as unplanned pregnancies. And as we know, this is the main challenge, or these are the main challenges when we look at our young people. We have VMNC, which has been proven to work very well, especially on a community level. It is expanded. We have PrEP and PrEP as well, and South Africa is really fast expanding PrEP even into public health facilities. We are trying to work around our youth zones to ensure that our young people are able to access PrEP. And then we look at STI management and other interventions as have been listed. We know that, again, behavior is also very important. It plays a crucial role, because even if one has access and availability of interventions, biomedical interventions, if behavior doesn't change, then there's still a challenge there. So we've also listed on a minimum level what needs to be done in terms of changing behavior, as well as structural factors as well are very important, as we know, in terms of ensuring that our clients have the knowledge that they need, they're able to reach where they need to reach to without any stigma or any challenges that can be thrown at them. We need leadership, and we need to ensure that there is support so that our young people are able to actually access our interventions in combination. Next slide. The next slide actually talks to our progress in terms of the GPC, our Prevention Coalition. This is 2020. And we can see that as a country, while the target is actually, we can see that incidence is going down. Our target was a reduction by 75%, but we see that we have, for example, number of adults newly infected declining from 270 to 190,000, and that translates about 49%. We see also in young people, there's over 50% reduction. However, while there is progress and traction, we can see that it is still not as fast as it should be, in terms of the targets of the Prevention Coalition. And when we look at the bottom, we are seeing interventions and our progress there. And when we look at our dashboard, we see that we're doing relatively well. I mean, we scored good actually in terms of the condom programming. And the main challenge is with prevention in terms of people who inject drugs. And then with the other interventions, PrEP and MMC, we are actually low, but we are actually increasing with time. Next slide, please. So why are we looking so much to young people? And South Africa, as in most of the countries, have a higher burden, as I've mentioned many times, which is lying within our youth. And looking at this here, we see that there was a study, actually a phylogenetic study that was conducted in KZN, which actually showed that young people between the ages of 16 to 23 actually get infected mainly by partners, male sexual partners that are higher than their age, like between 23 to 25. And we look at this, and it becomes a cycle. The young people also, young females, get older, and then they actually infect their peers, who then get older and infect the young people as well. So it becomes a cycle. And if you look at these arrows that are actually interlinking here, we see that they actually go forward and backward, which means that this becomes a cycle. It doesn't stop. And what we need to do is to ensure that we we cut the cycle and we stop the infections at all the different areas where we can actually see that there is a transition or transmission and or acquisition from a certain age group to a certain age group. And this is where the previous interventions that I've shown actually are very important here, because we see that if you look at the men, 23 to 35, and we expand MNC there, medical male circumcision, and they use condoms, obviously testing would have been entry point, then we're able to curb or to bend the curve of infection or instances has been shown. And young people, we have more interventions now, especially the PrEP-based interventions. At the moment, we're still expanding and implementing the oral PrEP. And we also provide condoms, male and female. So we are able to actually provide such a certain kind of like minimum package of interventions there. And we have, or we're driving these interventions through youth zones, and youth zones are spaces in facilities that are actually allocated to young people. And in terms of training the service providers, in terms of youth friendliness, the services are provided in a youth friendly manner. The actual space itself, or the ambience, as young people would refer to, is actually youth friendly. So we are using this to actually transition or to work with young people in terms of providing the services. Next slide, please. This slide talks to our prevention indicators. I won't go too deep into it, but if you look at it, we're looking at mostly what I have already kind of mentioned, the burden. We're looking at indicators of incidence and prevalence. And we say that the new infections, actually, while our strategic plan or objective is to reduce incidence by half, even with our strategic plan within the Department of Health itself, 2020 to 2025, is to reduce incidence in youth by 50% by 2025. And in order to do this, we need to be able to move and provide condoms and increase, advocacy and ensure that we actually look at the gender as well. And when we look at gender and new infections, you can see a 1 in 3 ratio there. And I'm not going to go one by one, as I was saying. We're looking at different provinces that have different burdens because of different dynamics. And also, we actually are looking at response to biomedical interventions or biomedical prevention, and you can see our ratios there. Next slide, please. And this is especially between the 15 to 24-year-old. So what are the main problems with condom use? When South Africa distributes so many condoms, and that will be detailed in the next presentation with my other colleagues. We can see that when we look at the household surveys that we have, usually every other year, we look from 2002 to 2017. While between 2002 and 2008 or 12, we see a bit of what we can see as an increase, and that's if we look at...
Dr. Thato?
Yes?
Can you please come closer to your mic? We lose you in between. Sorry to disrupt.
All right. Sorry about that. Am I clear now?
Very.
Okay. Okay, so we are looking at condom use now in South Africa based on our household surveys, because this is one of the main ways that we're able to track use. As we know, distribution does not always translate directly to use, so we need to look at the use even if we are monitoring distribution. So when we're looking at young people 15 to 24 from 2002 to 2017, we can see that while in the first 3 years, or 3 surveys, 2002 up to 2008, we are seeing a bit of an increment in terms of use in both male and females, while males are a little bit higher. But we can see that we now have a bit of a drop in 2012 and then constant when we get to 2017. So between 2012 and 2017, we don't see any major change in terms of condom use. And this is what prompted the department then to look into other interventions and measures, such as branding, such as communication strategies, which will be discussed in the other presentation. Next slide, please. Our other challenge here also, we are looking at condom use at last sex. Again, that is the household survey that we're talking to. And we also look at consistent condom use by age. And again, when you look at between males and females, we can see that we are having a bit of a challenge when it comes to our females. So what we need, or what is our constant drive, our main objective is to ensure that we have consistent and correct condom use in order to ensure that we actually curb the transmission and or acquisition of HIV and STIs, or even to prevent unplanned pregnancies. Next slide, please. The one challenge, again, that our household survey looks at is multiple concurrent partners. And this is, again, a slide that shows concurrent partners between 2002 to 2017. And we see, again, if we concentrate more on the 15 to 24, that's where I will concentrate for the presentation, because these are the young people that we're trying to work with. We see generally in males a sharp increase between 2002 to 2012. And then in 2017, we see a bit of a decrease, which is good news. But we need to try and ensure that it actually really changes, that the mindset of young people actually changes. The challenge, the main problem is when we get to our females. While there was a constant there in between the two surveys, but we see that between 2012 and 2017, we are seeing another increase. So we know that the issue of having multiple concurrent partners increases the risk of contracting HIV, the risk of getting STIs, and also unplanned pregnancies, especially when condoms are not used consistently. So that's also a gap that we need to look at. Next slide, please. So I think what I've shown us is our challenges, when we say know your epidemic, so that you can know your response. So we know where our challenges are and how are we responding. In terms of the national condom programming, the National Condom Program as a government program in South Africa actually started in 1992. At the time, our condoms were not branded, and we did not even have artwork that you would actually say is a Department of Health artwork. And then a few years later, towards 1999, we actually had choice, where we actually put branding with the support of our partners, PEPFAR in particular, where we actually had choice as a brand for South Africa, which continued until 2015. And I'm just giving us a bit of a background so that it's clearer as we go through. And around 2015, we had perception studies where we realized, as you saw on our use, that condom use was actually not going up as much as we wanted it to. And when we had a perception study, we commissioned a perception study with the support of UNFPA through implementation of SFH, so Society for Family Health. We actually then got these responses that, our young people are looking at our government brand as not the same as other brands, in terms of youth, the way they actually look at it. We did not have colors, we did not have different scents. So that's what informed the move to rebranding and to coloring and scenting our condoms. And then we moved to the brand Max, which is short for maximum. That's the brand that we're using now. So back to our condom programming. Yes, condoms remain a cornerstone for prevention, as we have already mentioned. And we know that when condoms are used correctly and consistently, they will avert infections, as we are talking about, and they will reduce or prevent unplanned pregnancies. We know that condom distribution on its own may not yield the traction that we're looking for. That is why we know that the critical enablers there are promotion. So health promotion programs, advocacy through our sectors, through our civil society is actually very important, as well as the department itself. And in a multi-sectoral manner, really, advocacy is very important so that we're able to communicate to our young people as we distribute, so that they also have mechanisms of accessing condoms without going so much into public health facilities, where we know that there's major challenges of young people accessing facilities. We know that there's a need to maximize opportunities, synergies, and ensure that we get maximum impact in the country in terms of condom use, which is why we are actually looking at other interventions and support from partners as well, so that in a multi-sectoral manner, we look at storage, we look at warehousing, which are different dynamics that usually would affect your, even if you focused properly, but if we are unable to actually move commodities, then it becomes a challenge, because then you get to not have what you need at the right place at the right time. Next slide, please. And I think it is also critical to mention that South Africa also distributes between 600 to 800 million male condoms in the past 5 years or so, and also about 20 to 40 million female condoms in the past 5 years. And this is also because we have seen how critical it is to have access to condoms. I mean, our condom program is targeted at the 15-year-old and above. And we are looking at this to ensure that it is integrated in sexual reproductive health programs, in HIV programs, prevention programs, so that we're able to access. And what the picture shows here on the right is our now colored and scented Max condoms, as I've already said. We have banana, grape, strawberry, and vanilla. And at the bottom, you see the same on the female condom, which was not branded before, but is now branded Maxima, which is really the partner to Max. Still about maximum protection, maximum pleasure, basically maximum choice as well. So it still brings in the issue of choice, which is quite powerful in terms of young people being able to choose whatever they want, and being able to actually have it responds to their need or their request through the perception study. And we also had some, I spoke about health promotion. We have also partnered with our implementing partners and had some outreach activities and campaigns on the ground. We are still working on a campaign that is called Peace of Mind and No Regret. Basically to say that you use a condom, you have peace of mind, and you don't have any regrets, because then you don't have to think about a possibility of infection or a possibility of a pregnancy that was not planned at that time. So it's very important that, I think it's also something that we would have other countries maybe share what they have been doing, in terms of trying to increase use, access, and availability of condoms. Next slide, please. I'm hoping that I can still be heard properly. So we also developed a condom communication plan as a country, also with the support of UNFPA. And we are actually now, we have disseminated, but we need to have a consultative, bigger dissemination. We have been kind of like affected by our COVID disruptions. But the goal of the communication strategy is really to make sure that at the end of it all, we have consistent users of condoms. So we are looking at those people that were using condoms and kind of like stopped at some point for different reasons. We're looking at those who were not really consistent users, and we are looking at people that have never used condoms before. A lot of our young people need to also be introduced into condom use as they get older and they develop also sexually. And at the end of it all, as I said, we are looking at having consistent users of condoms, and correctly so as well. Next slide, please. Also looking at our communication strategy, we have different points that we need to consider or to take into consideration when we communicate. We're looking at our young people, the target itself. We are looking at how we should actually move or focus or distribute our condoms access. We need to address stigma. We need to ensure that we eliminate discrimination. We need to make sure that we know that the add-ons and the benefits of condoms are clearly communicated at different ages and different gender as well, because we know that we cannot really communicate with a 15 to 18-year-old in the same way that you would communicate with a 25 to 30-year-old, and male and female. We need to make sure that our communication is person-centered, so that our young people understand that they need to use condoms for the different reasons that they find themselves in at different stages of their lives. Next slide, please. We're looking at our successes in the program in South Africa. The South African condom program is majorly supported financially by domestic funding. And we actually fund more than 80% of the procurement. We also have condoms from partners and private sector. And we try to look at our condoms in a total market approach. The government capacity to manage the total market actually needs to be strengthened more. You know, we try to get more and more strong so that we are able to work through our technical groups, technical working groups and management structures to ensure that we're able to manage availability and accessibility. We have policies that are progressive. We have guidelines. We have implementing plans at provincial level and at district level. We have a very strong national QA system, the SABS. So all condoms that are distributed or that are provided to South Africa, at least in the government sector, are actually taken through SABS to make sure that they actually comply with our quality assurance systems. Our government condoms delivered through a national tender that actually ensures standardization in terms of specifications and quality assurance. And it actually supports also sustainability, that coupled with the fact that we use domestic funding. So we are able to actually work with our target market and ensure that the support is constant. We have partner support as well for distribution. Our prevention partners also support us in terms of distribution and advocacy. And we have also our policies and guidelines actually talk to or recommend integration of condoms into all our HIV programs as well as our SRH programs. And I've talked to the communication plan as well as rebranding and the support that we actually get mainly from UNFPA technical assistance, but also support that we get from our other partners as well. I think this might be my last slide. Let's see the next slide. Okay, successes should be followed by challenges. So I talked about our tender that we distribute through a national tender that is actually managed administratively by the National Treasury, but also technically through the National Department of Health. So we have our technical working groups, our bid evaluation committees and bid adjudication committees between the two departments and provinces as well, to ensure that everyone actually is involved on the make input in terms of the specifications and what the department needs, including targeting as well. So the one thing that actually affects or threatens, I would say, security of supply, for lack of a better word, at contracting level is the fluctuating rand-dollar exchange. As we know, when you put a tender in place, yes, you have provision for price adjustments, but a tender is actually, guided and governed by specifications, treasury regulations, the PFMA. We can't just keep changing prices just because today the rent is 50 bucks, tomorrow is 100 rand, the following day is 20 bucks. So that is the one thing that affects our suppliers, mainly because, as you know, South Africa, where it's sitting, we don't necessarily produce. We have manufacturers, about 2 or so now, but even if we do have manufacturers, we don't grow rubber. So things like raw latex is still imported. That provides a challenge because that is actually paid for in dollars. So the rand-dollar exchange of fluctuations actually can threaten our supplies. So the rest of our suppliers are actually importers. So again, as we see, even if we had planned, this forward risk that we look at in terms of the rand-dollar exchange becomes a challenge. I won't even talk about what we have now in terms of COVID, because that has made or given us major problems in terms of the fact that, during hard lockdowns throughout the world, manufacturers had stopped, and then people get sick, and then manufacturing is actually then decreased. So South Africa is affected just like everybody else. Then moving beyond those challenges, we also know that the supply chain itself needs to actually be monitored and strengthened. And as we increase our challenges, we also need to ensure that we increase our primary distribution sites and our warehouses. So we need to man those as well, because the more we increase, it means we need human resources as well, so that people are actually able to manage, because we still manage our condom program manually. We are just starting with the support of Global Fund to go on a stock visibility system, but it is just starting. On top of that, we are still, I talked about a target of about 600 million to, or rather a distribution of about 600 million to 800 million. And that actually, without a proper stock visibility system, becomes a challenge, because it means that we have to man manually and report as such. We need robust strategies. We say that even as much as we increase our distribution, the uptake remains low. So even though the government keeps going back to young people through perception studies to say, so what is the challenge here? What is the problem there? And we try to respond. But that is the one thing that we've seen as a gap, because then it leads to also correct use sometimes may actually be one of the reasons why young people stop. So training and mentoring becomes important. We know that in terms of SRH, we have had a policy that was promulgated through the Department of Basic Education a few years ago. But just like in many countries, sexual reproductive health, while it is actually recommended and implemented in schools, but when it comes to actual condoms and translating policies into implementation, we still have some challenges that we need to strengthen. We have to be looking at misuse, that leads to wastage. We need to cap the myths. And as we know, myths actually spread. And if they are not kept, they can actually cause more damage. We need to keep increasing the demand creation and our IEC to ensure that our communication and education remains strong. And again, we also try to work or reach out, or we still need more support from the private sector, because while we know that we have condom brands that are privately owned, it's very important that we actually work together in terms of at least advocacy and communication, so that we all say the same thing and we are on the same lane in terms of advocacy and communication. So these are the challenges that we have in our condom program, and it would be good also to actually know what other some of you are doing to try and cap some of this. And while we look at our program is relatively doing well, but it's good to acknowledge that there are some challenges that need to be ironed out, and then we will actually do better. Next slide. Okay, so that was the next slide. So we'll get now into procurement and supply chain. Let me hand over to our chair. Thank you very much.
Thank you very much, Dr. Thato. For the questions at the end of the presentations. Colleagues, we're going to part 2A of our presentations, which is procurement and supply chain. Livhuwani is the Deputy Director for Condom Program within the HIV Prevention Strategies Directorate of the Department of Health. Her portfolio includes management of the National Condom Programming, participating in the procurement committees for condom procurement, monitor the distribution of the condoms and lubricants, as well as support the conducting of the gap analysis and training for staff members for the condom program. She has over 13 years of professional experience gained in public health sector. She has a national diploma in biomedical technology obtained from Val University of Technology, as well as a national diploma in safety management obtained from UNISA. Livhuwani, can I hand over to you to give us your presentation?
Thank you, Chair. Thank you for this opportunity.
Your name properly.
Pardon?
Did you get that? Can you please tell us your name properly? I think I'm just messing it up.
Oh, okay. No, it's fine. My name is Livhuwani Lifhiga. Am I clear? Can I continue?
Yes, please to continue.
Okay, thank you. As Dr. Thato had already started to give us a background of the condom program, I'm going to take us through the procurement process. The current tender for condoms runs on a 3-year cycle. So currently our tender is from started on 2018 and is going to come to an end this year in September 2021. So what usually happens after every 3 years, there's a new tender that comes into effect. Currently there's a tender that was advertised, and now the tender has closed. So we are currently in the process of trying to select the suppliers for the new upcoming tender, which is also going to run for another 3 years. And it is managed by National Treasury. As the National Department of Health, we provide technical support for the tender. We currently have 23 male condom suppliers and 9 female condom suppliers on the current tender. And then the procurement of condoms is disseminated to provinces, meaning that even though the tender is contracted as a national tender, the provinces are responsible for procuring the condoms on their own. They are given a budget per province for the procurement of the condoms. As the National Department of Health, we also buy a buffer stock. The buffer stock that we buy is used as a backup for the provinces in case maybe there's a shortage of condoms in the provinces or there's a delay in delivery for condoms. That's where the buffer stock usually comes into effect. Provinces will reach out to us if they've got a shortage or if they've got a challenge or a delay, and then that's when we are going to assist and give them condoms. And currently the distribution, the number of condoms that are required for distribution for a year, they are calculated for with the population of the country from 15 years and above. Each province has a different target depending on the population of that province. Provinces are required to procure more than they need for the month. Preferably, we usually advise them that they must procure stock that will last them for 3 months so that they also have buffer stock on their own. Suppliers not having enough stock in the country, it actually delays the procurement process, because at times you'll find that provinces, they require more stock than what the supplier currently has. So it falls as one of the challenges. Next slide, please. The condoms that are procured from the contracted suppliers, they are delivered to PDS sites. The PDS sites are the warehouses where the condoms are delivered to. So each province has got a PDS site. A PDS is not one per province, they've got more than one. So the PDS, it serves as a big warehouse for the whole province or for a district. So as the condoms arrive from the supplier, they arrive at the PDS, and the storage space or the storage area where the condoms are stored, it should be away from direct sunlight. The boxes must not be in direct sunlight, and the boxes must be placed on pallets. This is also to make sure that the stock is properly stored in case where there might be, let's say, for example, flooding or there's a leaking pipe, the boxes won't get damaged because they're going to be on pallets. So it's very important that they are not put on the ground, they must be on pallets. There is a detailed SOP that we developed as the National Department of Health, and it was circulated to provinces to assist them so that they know the storage conditions, how they are supposed to receive stock, how they are supposed to order stock. So everything that has to do with ordering and also with storage of condoms is there in the SOP that was developed. The condoms are then moved from the PDS site to the SDS site. The SDS site is a secondary distribution site. For example, we talk of your salons, clinics, taverns. Those are the secondary distribution sites that the condoms are moved to. These secondary distribution sites are important to have as they are usually located within close proximity to the population, because you know most of the population, they always go to clinics, salons, taverns. So those places, because majority of population, they frequent there, it's important that they must always have condoms. We have more than 300 SDS sites nationwide, and we are currently exploring other sites of distribution like your toll gate points. Because as we know, currently with the COVID pandemic, there is restrictions in movement. So we are continuously trying to look into different ways of how can we reach the population so that the distribution of condoms does not go down, because as it goes down, we know that it means that we might have more infections because people might not be using condoms. So we are consistently looking for different ways of trying to reach the population. There is an ongoing need to intensify condom distribution as well as identify non-medical condom distribution outlets to increase access to condoms in communities. Next slide. On this slide for condom procurement and distribution process, what usually happens, we've got a tender, as I indicated. The tender is advertised, and as interested parties, they apply for the tender, and then afterwards there's a selection process which is done through National Treasury and partnership with NDOH. And then after the suppliers are contracted, that's when they are given the tender. After they receive the tender, the condoms that they have, they need to undergo SABS testing, as it was indicated by Dr. Thato. So all the condoms that are distributed to the public, they first have to go to undergo SABS testing. So once the condoms have passed the SABS test, that's when the condoms are ready for distribution. So the condoms can either pass the SABS test or they can fail the SABS test. So failed batches are not distributed into the public. Hence, it's important for our condoms to be tested so that they meet SABS checks if they meet all the standards. And then we also have forecasting, determining the need also for the whole nation and also per province. We have logistic officer at national, and other provinces also have him as well, who assist in terms of calculating the amount of condoms that are required per annum, and also that are required quarterly and also required monthly. So there is a breakdown in terms of how many condoms are required for the year, quarterly, per month, and so forth. Provinces then place orders with the suppliers that have won the tender. They place orders based on the need that they are going to have as a province, and they also have to look at the annual allocation and also the quarterly allocation as well. After the condoms are then ordered from the suppliers will deliver the condoms to the province. The condoms arrive at the province to a PDS site. So at the PDS site, that's when condoms move to the SDS site. The suppliers are then paid by the province or by the NDOH, depending on where they received the order from and where they delivered. They must provide proof of delivery to the province, and the province is going to pay them based on the proof of delivery. So when the suppliers deliver the condoms at the PDS site, there has to be a person on site to receive the stock, to check what was ordered and also what is being received, to ensure that the information is indeed correct, so that when the invoice is paid according to how the work was conducted. Okay, and then when it comes to the SABS test batches, they also need to be monitored. As SABS test the batches, they send their report to NDOH and also to the supplier to see that if the condoms have passed or if the condoms have failed the quality control processes. So they are constantly monitored as they are received from the SABS. And there's also, like I highlighted, that there should be a person that will check the goods that are being received, if they are indeed in correct order, and if it complies with the delivery conditions. Next slide. Male condom distribution 2016 to 2020. As Dr. Thato had highlighted a bit earlier, our target and our distribution, it varies per year. As it varies per year, what we usually do, we go to the public or we partner with an NGO or an organization which is willing to assist us with research so that we can find out why is the distribution going low, what are the challenges. Such researchers, they assist us in terms of reviewing our condoms and also to review our promotional material as well. So as we can see here, from 2016-17, our target was 750, and then we actually distributed 917 million, which was above the actual target. And then in 2017-18, our target was 850, and we distributed 694 million. So what actually also happened during 2017-18, we changed the reporting process. So as a result of changing the reporting process, some of the provinces, they were not clear in terms of how to report properly, which actually led to underreporting and affected us in terms of the number of condoms that were distributed. And then 2018-19, the target was 953, and then the actual was 657 million. As you can notice, it's starting to go on a decline as the years are going up. So during the 2018-19, there was also a process that we underwent, which started in the current tender. Sorry. So what happened? There was a rebranding process. So the rebranding process, as we know, the government of South Africa started with the choice condom. So the choice condom, when it started, people started using it, but as years went on, they were not favoring the choice condom. They started to complain to say it's got rubbery smell, and then it makes noise. There were a lot of concerns about it. Hence, we then shifted to rebranding the condom, no longer calling it choice. And then we had to call it Max. Max is the female, Max is the name for the male condoms, and Maxima for the female condoms. So like it was highlighted before, both the male and female condom, they are scented with different scents. So that is also to eliminate the concern that was raised by the public that the government condom has got a rubbery smell. So as you can see, as the South African government, we've been trying our level best to meet the standards of the public, and also to try and compete with the private sector to make sure that the quality that we offer is exactly the same as the quality of condoms that is offered also in the private sector. So for our current actual 2020-2021, as we can see that the target was 850 million, but we distributed 537 million. This one of the issues that actually affected our distribution, it was the COVID pandemic. As we all know, we had a lockdown. So the lockdown affected a lot of movements of commodities. It also affected a lot of movements of individuals as well. So it affected our target, and we did not reach our target. Hence, as a result, we are continuously trying to look into different ways of how can we incorporate distribution of condoms into the COVID services that are currently there. For example, we're looking into a distribution of condoms at the testing sites where they test people for COVID. And also, we're also looking into distributing the condoms at the toll gates as well. And we were also looking into distribution of condoms through food parcels that the public was being offered with social development. So there are different things that we are currently looking into to ensure that the uptake of condoms does not go up, does not go down, but it continuously goes up. Thank you. Next slide. On this slide, we've got the female condom distribution from 2016 to 2020. So currently, if we can look at our slide, we actually haven't reached our target for the female condoms ever since we started with the distribution. But the main challenge, it was that people were not used to the female condom. So there is still more promotion which is required in terms of promoting the female condom, and also more training is required for the female condom to ensure that we correct misconceptions that are there in the public, and also to encourage people to use the female condom, because the female condom, it puts the power in a woman's hand. So we need to empower more women about the use of female condoms. It's not only a man who can carry a condom, but a female as well can carry a female condom. So we don't, females need not to rely only on the males for carrying condoms. Next slide. So on this slide, it's tables that are basically just sharing the information that was there on the bar graphs of our distribution for 2016-17, where we distributed 122%, we exceeded the target. And then 2017-18, our distribution percentage was 82%. And then 2018-19, we distributed 69%. And 2019-20, we distributed 65%. So as you can see, colleagues, there's a need for us to relook the condom distribution and also to dig deep to see where are the challenges, because when we started, we were doing well. Now it looks as if the condom distribution is going down, even though we know that it was one of the things that affected the distribution was COVID, but we must also look if there aren't any other factors that are contributing to the low uptake of the condoms. Thank you.
Thank you very much. Part 2B of our presentation, colleagues, is going to be addressing domestically financed and sustainable condom programming. I am going to request Mr. Ntabiseng Khoza to give us this presentation. He is currently the Director for HIV Conditional Grant at the National Department of Health. His portfolio includes management of the comprehensive HIV and AIDS conditional grants, finances, as well as NGO funding, also including forging partnership with key stakeholders such as civil society through the NGOs rooted in local communities across South Africa, as well as manage and support the donor funding that supports the HIV and AIDS programs within the Department of Health. Mr. Khoza has more than 24 years of professional experience in the public health sector. He is the member of the Southern African Institute of Government Auditors and Institute of Internal Auditors. He holds a national diploma in accounting and computer practice, bachelor's degree in accounting, a postgraduate diploma in health systems, as well as various certificates in leadership and management. Over to you, Mr. Khoza.
Thank you, Chair, and good afternoon, colleagues. I'm going to take you through a few slides that deals with the, just complementing the slides that my colleagues have already spoken to. So just in terms of background, in terms of financing, the condom program is one of the, in South Africa, one of the HIV and AIDS interventions and funded through a basket of amongst the other interventions, such as the HIV testing, prevention of mother-to-child transmission, and the biggest being of course, the care and treatment program. And I think South Africa, we have been fortunate that in 2001, in the UN AIDS Assembly, there was then that declaration that by heads of state that funding of the HIV and AIDS program should actually be a part of the pledges that comes from each country. Member states should then pledge to contribute about 15% or commit about 15% of the total annual budgets to HIV funding. And in South Africa, through that process, I think from the 2002, worked in ensuring that we actually get to, as a country, to comply with that pledge and resolution. of the UNAIDS General Council Assembly. With that, just in terms of numbers, the HIV and AIDS was first, as we know, discovered in South Africa in 1982 and managed as a program in subsequent years. But of course, most of the data in terms of testing came through in 1983. And of course, I mean, that it had been had a kind of longer kind of stay in the country even before this huge commitment came and by the country in 2001 in terms of dedicating resources to the response. Then with that, just zooming into the condom program, condom then, as I said, forms part of the condom program, forms part of the basket of interventions that we actually get to fund. Currently in health, I think in 2003, our budget for HIV and AIDS moved from then about just over $500 million, half a billion rands per annum to almost double, which was 1.2 billion in 2002-2003. From that point on, the program has actually been growing, especially driven by the treatment program. However, as you actually are dealing with, and as you colleagues will remember at that point, the country was actually dealing with a situation where people were actually dying en masse, and we had to have a response that says, how then do we deal with the issue of arresting the number of infections, but also ensuring that those that are in treatment, require treatment, get that. So the condom program then benefited as a result of that. That in terms of scaling it up to say this at that point was the only known way we could actually prevent, besides abstinence and all that. Should there be to cap transmissions, we had to have a condom, at least for each sex act in the country. So fast forward, I think around 2016, we actually worked on what we call the investment case. And in here, we're actually doing a study to say, we know that, I mean, there's the research, WHO would come up with new findings of researches that are done over the world. But there's also quite a lot. I mean, we had microbicides, we had condoms, we had PMTCT testing, infant testing, and quite a lot of other interventions that were coming through to say this can help us cap the HIV infection. However, given that we needed to have a study that will say what will be cost effective, give us the return on investment on a higher level in terms of cabin transmissions, but also being cheaper in terms of how that can be done. And the result of the study that was done, called the investment case in South Africa, actually showed condoms to be the most cost-effective HIV intervention by then, at about 90%. And then we as Livhuwani has also already alluded to, we actually deal with this in terms of budgets that are allocated, because then at national level we would allocate through the grant, but then Livhuwani has already indicated that the procurement of these condoms, even if they are on a transversal contract, are actually happening at a much lower level, sub-national level, at provincial level. So funds are allocated to provinces, and while we still will retain about 20% of the budget and procure for buffer stock and for us to be able to intervene should there be issues in terms of security of supply. The bulk of the condom budget actually is transferred and managed at the provincial level, even though it's actually determined at the national level. The condoms have spoken to this part that they are procured through a transversal contract tender process. Livhuwani has actually alluded to that in terms of step-by-step how that is done. We actually then, in terms of budgets, would work on issues around just ensuring that there's a accurate capturing of expenditure, accurate capturing of condoms distributed, just so that then, and looking at other higher level issues like the population and demarcations in terms of various districts and provinces, just to ensure that when you do targeting and quantification, it's actually on the basis of us being able to reach people that we need to reach. Then there's also an issue around the importance of having to track the expenditure to ensure that we know on a year-to-year, we actually then are able to do a retrospective analysis, while we also use that information to inform budgeting going forward. Next slide, please. So on this slide, this then talks to when we did the investment case, we actually looked at a basket of interventions that could look into I mean, the areas that as a country, when we go to National Treasury, would say, give us money, and if you give us money and fund our response as a country in line with the national strategic plan that we have, these are the interventions that we have that are known to be and proven to be effective. But then there's also an issue to say we can never have enough money to be able to fund and cover all the interventions. So with the investment case, we're trying to get to see which ones would be able to, if we were to rate them on a scale, which ones will then be and start allocating resources on the base of from the highest to the lowest. And when we get to areas like PrEP for discordant couples at that time in 2016, the issues around microbicides and PrEP for adolescents and infants PrEP for sex workers and all that, they actually got to rate much lower when you compared those with what we'd had as condoms. That was in 2016. And we have actually rerun the investment case and found condoms are going to be the most cost effective, in fact, this time at 95%. The study is not yet signed out for publication, so but will soon be. And I think through the SANAC, we'll be able to share that information. But with this, I was just indicating, you know, backing up the information that I just shared on the first slide. Next slide, please. So on this, and I just realized that, you know, data on the exercises did not come through on the graph that we have on the left side. But what we're trying to indicate here is just a timeline from 2014 until 2020 in terms of financing of the HIV and TB response in South Africa. That you would see that the bulk of the proportion, like in 2014 in grey bar, 15 billion rands of the response was actually coming from the South African government coffers. And of course, then we would have Global Fund and PEPFAR being some of the key partners that will assist in terms of financing the response. But of course, the bulk then is domestic resources. And again, as you look extreme on the extreme right in 2019-20, you'd see that that actually grown from about 15 billion rands in 2014-15 to somewhere around the almost just above 37 billion rands being funded, being the response for HIV, just HIV and AIDS in South Africa. So almost double what we had in the year on your timeline there in 2014-15. Next slide, please. With this, this is then that just showing the condom expenditure, I mean condom budget extracted from those billions that we just indicated in the previous slide. Here we just isolated condom budget for both male and female condoms. And you'll see that again, if you reverse the timeline and look at start with the extreme right, in 2017-18 financial year, we had condoms budgeted at somewhere just below 1 billion rands per annum. And that actually scaled up to a point where we are in 2021-22 financial year, being somewhere around 730 million rands per annum. Of course, there's that dip in 2019-20. And if you remember the figures that Livhuwani showed in the previous slides, when we looked at the condom distribution, there was an issue in that financial year. And then what then happened was, because we're sitting with suppliers that were not able to deliver condoms, but also we were sitting with challenges of budgets lying unspent. And what we did was just a redirection of resources from condom program to other key priority areas, just so that we don't get to lose the money in within the HIV and AIDS program. However, a subsequent question might be that then what happened in terms of condom distribution? when you look at the one slides again, you'll see that the year prior, we actually had a higher kind of stock holding. And in the following year, we were able to then still draw condoms from the buffer stock or whatever we had holding either in our secondary distribution sites or the primary distribution sites, or what we hold at national as buffer stock. Next slide, please. So on here is one of the analysis that I was talking about, and this is again part of the bigger study that we still are to publish, and the more detail will follow as soon as most of the figures that we want to still go back and verify will be verified. However, we do analysis like this where we actually get to match financial and non-financial information. So we looked at the total number of condoms distributed versus the expenditure in terms of what we paid for those condoms versus what we had planned in terms of budgets, like the slide that I showed before. So here we actually are doing a analysis that looks at how much does it really cost in the whole condom value chain, from the storage, from the personnel that you employ, the commodity itself, transportation, all those other things that needs to come in, marketing and all that. How much does it really cost a country to distribute a condom? So we had a spending per condom kind of analysis. And on here, on the trend that we actually had established in previous studies that we did around 2015, 2016, actually had given us a figure of around 6 cents per condom distributed. And we then went into an analysis that the latest one that you see in terms of that a trend bar in blue. You'll see that actually starts lower and then goes up and then dips. The reason why the reason for that dip there is that this is the time where we had issues around reporting. So the expenditure is there, but then even though it's not at the level at which it was in the prior year, yes, however, the distribution in terms of condoms at that point was actually affected by the number of condoms reported. So if you look at the bars, this slide should be read with the slides that Livhuwani presented in terms of the distribution of both male and female condoms, and look at those years, you probably would see that it actually carries from 2018 to 2019-20 financial year, that these figures are actually not reflecting the exact kind of situation that we have in the country. And I thought I needed to share this with you, that it might look all rosy and we seem to be doing quite well, but we still have challenges, especially when we've got to do this kind of value for money analysis and various analysis that you might want to do. So as we do analysis on spending per capita per HIV, PLHIV in South Africa, spending per capita per person on treatment, we also do spending per capita per person tested on HIV, and spending per capita or spending per condom distributed. So this is some of the information that we still need to be able to collect, so that we then can inform, that will help us inform the forward planning and allocation of resources. Next slide, please. These are some of the issues that needs to be looked at as we go forward. I've spoken to this at length, I think in the previous slide, the first bullet, there being linking of finance and non-financial information. The underlying biggest challenge that we currently are sitting with, and I think that's what our experience has been across when you compare with other colleagues, especially our colleagues in Swaziland and Lesotho, was that we realized that we have common challenges around coding and labeling of expenditure. So it could be that we know that we have allocated about 730 million rands for condoms in the country. The expenditure comes out to be somewhere around 500 million rands. But when you look at the number of condoms that we know we have procured and distributed, the number then exceeds the expenditure. In some cases, the expenditure exceeds the budget. In some cases, it's the figures are translate to, when you compare them province to province, that one province would spend somewhere around 17 rands per condom distributed, when others would spend about 8 rands, others would spend 13 rands. So that disjuncture is actually created by the issue around labeling of expenditure and coding of expenditure correctly as we capture it on our financial systems, but also ensuring that we don't get to look at finance away from non-financial information. The next issue we need to look at is the issue around reduction of a need for storage space. Yes, condoms needs to be procured, as we spoke about the procurement and supply chain process. But the challenge about on the finance side is that you would not want to just go and buy condoms and stockpile them and run the risk of not being able to, run the risk of not distributing all of them in time before their expiry date. So there are these issues around having to balance the issue of the need on the ground based on the total population that needs a condom or that we are targeting, but also ensuring that there's also health education, marketing of condoms, advocacy and all that, so that we generate a need on the ground amongst our communities to be able to demand condoms, and then procure and supply those, rather than having to procure en masse, store, because then you incur other costs and it pushes up your budget and expenditure in terms of condom distributed, as I've indicated on the slide on finances. But then again, the value chain needs to be monitored, just to ensure that all the stakeholders play their part. When you do quantification, it's based on accurate information in terms of baselines, but we look at engaging Treasury in terms of ensuring that the adequate resources that we require are available. We then engage our colleagues in the supply chain side to ensure that there's no kind of a gap in terms of not having a transversal contract or a contracted service provider or service providers to be able to honor orders and then deliver condoms as they are required. So it's all of those that actually needs to be looked in a full kind of cycle, rather than having to approach it in a silo kind of manner. So those are some of the lessons that I think we have learned over the years. We're still struggling along to perfect them, even though we might be seen to be actually doing quite well, which I would confirm that we actually are doing much better, but then we can do much better than we actually are doing now, as Dr. T has said earlier. I think this was my last slide, Chair. Thanks a lot.
Thank you very much, Mr. Khoza. Colleagues, we are not doing very well on time. We've taken much time with the presentations. As you've seen, we have tried to give you a comprehensive presentation looking at the epidemic, looking at the condom needs, looking at how we have programmed for condoms, looking at the procurement, storage and distribution, as well as we've discussed some of the challenges that we've encountered while we are trying to make sure that we are implementing a successful condom program in the country. So questions, comments, we have not seen anything in the chat box. So we would also want to take this conversation to say, for the countries that are here, if you have any question or comment or a lesson learned that has been successful in your country, you are able to share that information at this stage. Can I request 10 more minutes, colleagues, of your indulgence in this short webinar, so that we can be able to touch base and make sure that we close the meeting while we've covered all the questions that are required. I'm going to ask my team to check if there are any hands on the, or any question on the chat box. For now, I'll give to Rosemary.
Thank you, moderator, and thanks to the South African team for sharing with us your experience in moving this massive undertaking. I must say it's massive, because once in a while we reached 300 million to distribute, and it was a crisis. So I can imagine what it means to run all that. Madam Moderator, I have several issues. I don't know whether I have the time, but I can run through quickly. For the first part of the presentation, I think we can relate with some of the issues. And my question is, for your evidence generation, have you had a focus on risk perception in terms of HIV, STIs among the young people? It is an issue with us because HIV is no longer an issue. Number two, what could be the role of the new biomedical interventions, especially PrEP, VMMC, and how do your target beneficiaries perceive the protection they get from that vis-a-vis condom use, vis-a-vis sex with a condom? We've had a challenge here, and sometimes the communication for those biomedical interventions actually decampaign condom use. Then we also have issues around condom use for prevention of pregnancy. I don't know what obtains in your context and how you do marketing or condom promotion for that. I had a question. Is the government condom free? And if so, how does it affect uptake? At some point, we had the same question where people were thinking that if something is for free, perhaps there's a problem with it. And indeed, to the extent that some people still do pay for the free condom from different points at some point. So is there a problem with a free product? And to what extent does that free government condom impact the TMA approach? What is the perception from the private sector? I saw a challenge that they are not fully on board, but how does the government free condom affect the other channels that would market the condom as a lifestyle? And I had a question for the procurement side of it. You do population-based forecasting and quantification. Do you have instances of overstocks? Because we were doing that in Uganda until the UNAIDS tool came in, and there was an impression that we were actually over quantifying, and perhaps it led to misuse of resources and overstocks. And also the question around the logistics management information system. We labor to track the free condom that has come from external funds. But in this context, I'm wondering if the provinces are the ones that procure, what are the barriers to actually having a strong logistics management information system for this product? I thought I would ask that because I thought we were not attaching some great importance to that particular bit. And finally, for the funds, the domestic funding for CCP, how, I don't know how to put it, it's part of a bigger basket. It's part of a process that established that condom use is efficient, but I'm wondering whether the condom is pitted against the other interventions, and if not, what trick did you use to actually achieve that focus? In Uganda, I think the last study put the efficiency of condom use at around 10% to prevent new infections. And I'm wondering whether we are using wrong tools. Over to you.
Thank you so much, Rosemary, for those questions. Dr. Thato, can I ask you to start with the response?
Okay, I may have missed some of the questions. Please do assist, and also my colleagues. My colleagues can also assist where I may have missed anything. So I will start with the one for biomedical interventions. I think there was a question on what is the perception of also. Okay, that was a different one. But for the use of biomedical interventions, PrEP, MMC, and condom, I think that there was a question there in terms of doesn't that cause problems? So what we do is that we provide a minimum package of interventions, and PrEP, VMMC, and condoms fall within that that minimum package of intervention. But because we want them to still be taken, but at the same time we still want to sell the condom as well, we actually advocate condoms as a contraception as well. So even if one is still taking PrEP, we do have, and we need to strengthen this and probably even maybe advocate more or have more IEC. But we have been thinking of, a dual kind of way in terms of saying you can use PrEP, but you can still use a condom. Because a condom being a barrier, kind of like a method of prevention, can be used with everything. So when we try to train our counselors, community health workers, and people who actually communicate at the forefront, at the field and in the communities, that's how we sell that. And we're actually now trying to look at maybe studies where, and some studies have actually shown where you'll find that PrEP users may actually have an issue with STI, for example, because sometimes they may tend not to use a condom. So really, it's a combination. It's choice, but we also try to advocate so that users of any other intervention understand that a condom can be used together, but also a condom is also used as a prevention for pregnancy, so as a contraceptive, but also as prevention for STIs. Because whether I have done them, whether a person has circumcised or whether they're using PrEP, those do not necessarily provide prevention for STIs and for pregnancy. So we try to combine it in communication. I wouldn't say we are there yet or it's perfect. Or
Thato, please come back to the mic.
Okay, am I audible now?
Yes.
Sorry, it keeps falling. Okay. Yeah. So what I was saying is that we try to I will say sell, for lack of a better word, condom use in combination with other prevention interventions. Because while PrEP users may say, okay, I'm having a pill to prevent HIV, but then we can also say, but what are you going to use to prevent pregnancy? And some may or may not be able to access other contraceptives, but then again, there's also STIs. So we try to work on communication to get that point in. Perception, yes, our survey, HSRC survey, is just that we didn't put that slide there. But in terms of youth, perception is a challenge because there is very low perception in terms of, will I get HIV? They kind of like tend to still think it's for somebody else and not me. So we are then developing risk screening tools where you'll find that if one tests negative, then we try to profile in terms of risk. We have a tool that we developed with WHO to support that or to help with that risk profiling, so that young people understand that even though we talk about PrEP as used or recommended for individuals at substantial risk, but anyone who is engaging can actually be at risk of contracting, especially if the partner, if they don't know the status of their partner, or if they are not able to to communicate and negotiate condom use, because that is also another reason that anecdotally some young people give to say, at least if I have PrEP, then I can just take the pill because I'm not able to communicate or to negotiate condom use. So empowerment is very important as well for our young people. Introduction of the female condom so that they can actually use a female condom if the male partner does not want to use a male condom for whatever reason. Efficiency of condoms study have shown that it's actually over 80% if used correctly and consistently. So that's basically what we should be communicating. It's been shown in in many studies, and it has been published. Livhuwani, is there anything you would want to add, or even Dr. Khoza? I don't know if I skipped anything. Overstocking maybe in terms of focusing. So we had a study that we did, in terms of condom use per person 15 years and above. That's when we came to that 50 condoms per male per annum. And when we actually calculated that based on our population of 15 and above, which is about 30 to 35 million, it came to very close to 1 billion. So that's what has informed our targeting and our forecasting in terms of the numbers that we roll out that are so big. But that actually does not necessarily replace or displace the private sector condoms. It actually augments, because where we're sitting, I mean, South Africa is big in terms of population. If I'm talking about 15 and above, and I'm already talking about 35 million or 30 to 35, it's actually a lot of people. And we actually look at condom procurement kind of like in a compartmentalized way. That's why we talk about total market approach. I mean, we know that we have the free condoms, which is our government condom. It is free. I think that was one of your questions. It's free. And that's why we also try to put it on par with the private sector condoms, like by coloring it, by branding it, and by scenting it, so that it actually is not seen as inferior in terms of those other things that we see in the private sector condom. And there's a market for certain brands in the private sector. We also had the social marketed condoms that used to be distributed through PSI, but I think we all know that the social part of condom programming is actually now moving towards private. So we kind of like have a gap now there. But condoms total market approach is used in that way. There is targeting, is compartmentalized per population. There are populations that will use a free condom. There are some that will use the social marketed ones, which is a little bit cheaper, for lack of a better word, as compared to the private sector one. So it's choice. But what we have seen is that there are other things unrelated to price that would direct one to using a free government condom or a private sector condom as compared to that. There's also this perception that free is poor, but when we look at our quality assurance in the public sector condoms, it's very high. So we actually do try to pan quality as well, so that young people understand that that perception of poor and free and poor does not necessarily stand in this case. Okay, let me pause there. And let maybe my colleagues, if there are any questions that I missed, or if there are any gaps in terms of my responses, maybe they can help. Mr. Khoza and Livhuwani. Thank you.
Thank you very much, Dr. Thato. Mr. Khoza, if you can check the question on the chat box and please respond on that question for us. But as Thato had indicated, as we introduce new HIV prevention commodities into our prevention basket, we tend to lose focus on the condom program. And that is the work that we've been doing with our ACSM program, making sure that the advocacy, social mobilization, and communication interventions continue to take place. As SANAC, we are supporting the Department of Health around the condom programming through ensuring that our key populations sectors, as well as civil society sectors, also contribute and drive the messaging around the condom use. We are implementing the comprehensive sexuality education in schools that also supports some demand creation for condom use, as well as prevention of sexually transmitted infections, as well as teenage pregnancy. So we try and make sure that there is a multi-sectoral approach and a multi-sectoral response on ensuring that the demand and use for condoms remain viable in the country. As we continue giving different messages as the program is maturing, we are undertaking the campaign of You is Equal to You, undetectable equal to untransmissible. And these are some of the campaigns that we also continue to emphasize the use of condom. We went through a drive of a treatment as prevention, but we also maintained the condom messaging. So we continue to make sure that we communicate the use around condoms, promote in our women and HYW platforms, promote the use of the female condom that also continues to support the uptake around condom use. So Mr. Khoza will respond to the question in the chat box around financing and focusing on financing for condoms while we compete fiscally with other HIV prevention commodities, as well as our expensive and continue to grow treatment program in South Africa that is also close to 95% funded by our domestic fiscus. So in terms of the fiscal overview, we try and make sure that we prioritize HIV prevention when we are allocating budgets, though we have not met the UNAIDS requirements in terms of our dividing our budgets for prevention, but we also try and maintain the balance and make sure that we've got enough HIV prevention commodities to take down our HIV incidence. So at this stage, I'm not seeing any other questions or comments. I'd like to quickly move with the agenda. We've only have 5 minutes left for our countries. If there are any take-home messages that we would like to share with us, this is an opportunity that we can open for you. If you don't have those take-home messages, I think we will work with the South Learning Network to make sure that we've got those take-home messages, including what have you learned, also sharing with us some of the successes that you've done in your countries. Mohammed, I'm not seeing any hands from my side for the presentations on takeaway messages.
Sure, thank you, Missy. This has been a really interesting session, and I hope that all of the members have enjoyed it. I know that perhaps there's a lot of information here, and this will definitely be sent to everyone with the recording, as is our standard practice. So that will also allow members to reach out to the South African team if they feel the need with any areas that they would like to cover. I do have one last poll, which is normally a feedback poll before closing. But I wanted to ask Missy, do you want us to just go back to your earlier poll results to have a look at how that has stacked up?
Yes, let's look at our first poll results, and then we'll take the second one. So this is our poll responses. Dr. Thato, can I put you on the spot to give us the memo for the questions that we've shared? How many condoms does South Africa normally distribute per annum? Dr. Thato, we can't hear you.
600 to 800 million.
600, 800 million, so 50% of our participants got that one right. What proportion of SA condom program is funded by the domestic resources?
Yes,
Mr.
it is. Okay.
Oh, you can give us, it's fine.
No, I thought it was me as well. So I'm getting ahead of myself. Yeah, it is greater than 75%. Let me stop there.
80% of our participants got that question right. Condom is, in South Africa is Celeste. Dr. Thato, seems I'm only left with you. You see, they are dumping us now that there's exams.
It's staying the same, at least if we look at the last two
The
surveys.
same, sorry. Sorry, it's staying the same as C.
So 30% of our respondents said staying the same. So this is the challenge that we are sitting with as a country at the moment, where our condom use is staying the same while we want it to increase. So we still busy, as Thato had indicated, developing some kind of communication campaigns to increase uptake of our condom use. There are approximately X number of condom brands in South Africa. Celeste?
Less than 30.
Less than 30. 40% of our participants got that one right, that we've got less than 30% of different number of condom brands in South Africa. It's still quite a lot of brands that we
30, yeah.
That are competing with the government brand. So ours is free of charge, as with all our services in South Africa. primary healthcare services in South Africa are free, so condoms are distributed for free. So, but we still have brands that we can buy over the counter in the different outlets. Who is the largest procurer of condoms in the world?
It's South Africa.
UNFPA.
UN? It's SA. Mohammed.
It's UNFPA.
Mohammed, please.
Mohammed, hi.
According to our
UNFPA.
condom experts, it's RSA. But if
It's
it's up for
South
debate,
Africa.
then it's a great debate.
It's
Right.
it's South Africa.
Yes, South Africa is the largest procurer of condoms in the world. If you look at the size of our HIV epidemic, you look at the size of our treatment program, and at least we are adding the size of our condom procurement. Seemingly South Africa is leading in that front as well. So those are the questions. So we are done. Mohammed, can we put up the next poll?
Sure. It's just the feedback poll for the participants to let us know how you found the session. After that, I think we're free to close.
Please participate in this feedback session. This is going to assist us as we support the South to South Learning Network in collaborating with the different countries and different stakeholders in bringing you some of the topics that are hot around sustaining and maintaining our HIV prevention response in the continent. So the poll is going to assist us to plan better. So if you could please quickly participate by clicking the correct answer. First question, was this session useful to you? Second question, was this session relevant to your country's context? Did this session address priority implementation needs and challenges? The extent to which my understanding of this topic improved. So if you can quickly give us the feedback, this is going to support and assist us as the South to South Learning Network as we continue to bring these cross-learnings across amongst the 10 countries that are participating in the South to South Learning Network. Again, colleagues, just to recap, our appreciation to the funders and supporters of the South to South Learning Network. Again, thanks to Genesis Analytics for hosting this useful platform and support for us, as supported by the University of Manitoba. We all know that Dr. Saul Johnson is always a visionary in trying to make sure that as the HIV epidemic is changing across the world, we normally do have opportunities to keep up with our response, with the type of research that we do and the type of coordination and collaboration that we bring. So thank you very much, Dr. Saul, for supporting the 10 countries with the Genesis Analytics supporting housing the South to South Learning Network. We would like to thank the Bill and Melinda Gates Foundation for always funding cutting edge innovations within the HIV and TB response across the continent, across the globe, and thank you for funding the South to South Learning Network. Would also want to thank UNAIDS, the Global HIV Prevention Network, for coming up with this concept as we continue to meet in the GNP circles, that we also get opportunities to discuss technical and programmatic issues outside of that space. Then they facilitated the birth of the South to South Learning Network. So we are thankful and grateful for this support, and thanking you very much, colleagues from other countries, to yielding to our support, our call as South Africa to say, come and learn with us as we continue to implement the programs that we are implementing. Again, thank you to our South Africa team for the sterling work that you've been doing and you've done to continue ensuring that in the midst of the epidemic and in the midst of the mayhem that South Africa is currently experiencing, we continue to prioritize the HIV and TB response and continue to be a sounding voice around ensuring that these services continue to be implemented and our communities continue to receive the commodities that they require. Thank you very much, colleagues. We will end there for today. and the South to South Learning Network colleagues will continue to communicate with you, share the presentations, and any other questions that are coming up, they will link you with us as the South Africa team to be able to respond to some of the questions that are coming up. So thank you very much, and have a good afternoon.
Thank you. Bye.
Thank you.
Thank you.
Thank you all.
Thank you. Thank you. Thank you. Bye.
And